or continue. Okay.
Okay.
Harmony. Harmony.
Sorry, doctor. I think I need to go log out and enter again the meeting because I cannot hear you well because
It's okay. You take your time. We will
okay.
move.
I will
We will go to Sim. Sim, you can start. Sim. Sim V. Yes. You share the slide and we can. Yes, you can share the presentation. Okay, please carry on.
Good afternoon, doctor and fellow friends. I'm Simwei from Group D. Now I'm going to present my case for OPD clerkship. This presentation today into 6 parts. Introduction. Nur Atira, who is 47 years old, is an adult female patient. She is currently in range of overweight with her calculated BMI of 27.9. She has no known allergies and has been diagnosed with urinary tract infection and type 2 diabetes mellitus. She has been prescribed with 4 drugs which are Bactrim, cephalexin, metformin, and sacchet urol. She has never experienced urinary tract infection before, and hence this must be induced by the recent high blood glucose level due to poor diet control. So the patient is facing the urinary tract infection symptoms, which are dysuria, the pain and burning urination, and overactive bladder, which is the urge to urinate with an empty bladder. Prescription-related. A few errors can be observed on this prescription. First is the misinformation for patient contact number and reference number. Prescribing that is not stated. Standard abbreviation for tablet is not written as TAB, and the is spelled error. Name is used for Bactrim and sacchet urate, which should be written in as sulfamethoxazole trimethoprim and sacchet citric acid, sodium bicarbonate, sodium citrate, and tartaric acid in generic form. First is the sulfamethoxazole trimethoprim will interact with metformin with increased effect by non-acidic drugs competing for renal tubular clearance. Adult dose for sulfamethoxazole trimethoprim should be 960 mg twice per day. Sorry. Next is the cephalexin will interact with metformin, which will increase metformin toxicity until hypoglycemia. And it has the same indication as sulfamethoxazole trimethoprim in treating bacterial infections. Thus, duplicated therapy may occur. Is the duration error for sacket euro, which according to MIMS, 1 to 2 sackets, which is 4 to 8 grams, should be taken for patient 4 times daily instead of twice per day. My recommendations for this prescription first is for the underdose situation for sulfamethoxazole trimethoprim. I suggested the doctor to change from one tablet once daily to 2 tablets of 400 milligrams / 80 milligrams sulfamethoxazole trimethoprim twice daily. And the drug interaction between sulfamethoxazole trimethoprim and metformin should be monitored closely with blood glucose level checking, and QT interval should be routinely checking with electrocardiogram for dose adjustment if needed. Cephalexin. It is an antibacterial agent which in class of beta-lactam antibiotic of first generation cephalosporin. It offers the same indication as sulfamethoxazole trimethoprim to treat the urinary tract infection in this case. But it has a shorter half-life, which may contribute to lower efficacy, and it is not recommended as the first-line therapy due to its high resistance and higher recurrence rates compared to other agents. Furthermore, it can also interact with metformin, which will increase the metformin toxicity until hypoglycemia. So I suggest the doctor to omit this drug since the sulfamethoxazole trimethoprim has been prescribed as the standard therapy in urinary tract infection treatment. It's the duration error of saccharate citric acid, sodium bicarbonate, sodium citrate, and tartaric acid. I suggest the doctor to change the duration from twice daily to 4 times daily as according to MIMS. And as the problem and excessive use may induce systemic alkalosis or hypernatremia and non-laxative effect, urinalysis is suggested to be carried out for therapy amendment if needed. The counseling points, there are basically 2 techniques being carried out. Technique for refill medication, which is metformin, and the next is prime question technique for new medications, which are sulfamethoxazole trimethoprim and saccharate citric acid, sodium bicarbonate, sodium citrate, and tartaric acid. Prime medication, which is metformin, it is an anti-diabetic agent to treat type 2 diabetes mellitus, and it is available in tablet form of dose 500 mg. So the patient is instructed to take 2 tablets twice daily for 2 months. The patient should also take this drug with food and drink plenty of water. By taking metformin, the high blood glucose level of patient should be controlled and achieve weight reduction. The common side effects and precautions that I have told patients have been listed in this table. First one is sulfamethoxazole trimethoprim, which is an antibacterial agent for infections. It is available in tablet form with dosage of 400 milligrams / 80 milligrams. And the patient is instructed to take 2 tablets twice daily for 2 weeks. The prescription has changed from 1 tablet once daily to 2 tablets twice daily as according to the former adult dosage guideline. And the patient should take this drug with food and drink plenty of water and continue to take the medications until finish the full prescribed amount, even symptoms disappear, to prevent relapse of infection. By taking sulfamethoxazole trimethoprim, the urinary tract infection symptoms facing by the patient should be relieved, and the common side effects and precautions that I've told patients have been listed in this table. The next medication is saccharate citric acid, sodium bicarbonate, sodium citrate, and tartaric acid. It is indicated to in the urological treatment and is available as effervescent granules powder. The patient is instructed to take 1 sacket, which is 4 grams, 4 times daily for 1 week instead of 2 times daily. And the patient should dissolve the granules powder in a glass of cold water 30 minutes after meals for administration. By taking this saccharate euro, the mild urinary tract infection facing by the discomfort facing by patient should be relieved. And the common side effects and precautions I have told patients have been listed in this dose. The patient can take it immediately once, remember, but if the time is almost close to the next dose, just skip it. Never take the double dose as it might cause toxicity. suggest patient to set an alarm as a reminder, or use application or pill boxes as a reminder to let patients take drugs on time to increase patient compliance. All three drugs should be stored below 30 degrees Celsius. For metformin and sulfamethoxytrimethoprim, both should be protected from light. And during the counseling session, I always keep an eye contact and listen actively to the patients to understand what problems she faced. For type 2 diabetes mellitus, I also give some non-pharmacological advices to patients, which is maintain low-calorie diet by avoiding sugary food and drinks, exercise regularly, drink plenty of water, and self-monitor blood glucose level. For urinary tract infections, I advise the patient to drink plenty of water to flush out bacteria and avoid plenty of coffee, alcohol, or spicy food, as it may cause irritation of urinary bladder. I also advise patients to always alert of the relief or discomfort of UTI, which is the dysuria and overactive bladder. And at last, I do a final verification with patient on the administration of the medications and ask her to follow up after 2 months. I also ask her to consult doctor or pharmacist immediately if the urinary tract infection symptoms is not relieved. The monitoring parameters, first one, the metformin, the efficacy should be achieved by control high blood glucose level and achieve weight reduction. For safety purpose, we should monitor the urine and blood level and monitor renal functions, liver function tests, vitamin B12 serum concentration, and also signs and symptoms of lactic acidosis. For sulfamethoxytrimethoprim, the efficacy should be achieved by relief of urinary tract infection symptoms. And the safety parameters including carry out the culture and susceptibility test, urinalysis with microscopy exam, renal function test, liver function test, monitor total blood count, serum potassium level, and serum sodium level. We should also closely check for signs and symptoms for urinary tract infections. And lastly, the target citric acid, sodium bicarbonate, sodium citrate, and tartaric acid. The efficacy should be achieved by the relief of discomfort of UTI, which are dysuria and overactive bladder. These are the reference I use in this case. And that's all from me. Thank you. Any question?
Okay. You are interested in questions. Okay. Okay, my dear student, then why you give 2 months follow-up? Any reason for that?
Oh, because metformin is a long life treatment. Type 2 diabetes mellitus is a long life disease. So we should give 2 months 2 months metformin to the patients and ask her to follow up after 2 months and check for the blood glucose level to adjust the drug since if the situation be in control or we need to add up the dosage.
Okay, that's why I'm asking why 2 months. This is a life issue, but is it a common practice in hospital that they call patient after 2 months, or it is your desire?
Yes. Sorry, doctor, I can't hear you.
Why you can't hear me?
Just now.
Now you can hear me?
Yes, clear.
Okay, why 2 months interval? I know that this is chronic disease condition, but is it due to some medicine effect that you call 2 months interval follow-up, or hospital for hospital pharmacy practices is like this, that they will call a patient for 2 months, or why not 1 month, why not 3 months?
As according to the guideline, metformin should be given 500 milligram twice daily or 800 milligram 3 times daily for consecutive 2 months.
Then
So if after 2 months the the symptoms is not relieved, so we can consider to add up the dose or add another oral anti-diabetic drugs or intravenous insulin or else.
okay, is it it means it is on early stage? to adjust medicine dose for the patient.
Yes.
But not if patient is confirmed or established patient. Then what would be the procedure? And may I know which guideline indicated 2 months?
According.
Is it Malaysia?
I think it's according to MIMS, due to my review.
Okay, try to make sure when you are saying something, you should clear about it. Okay. Okay, very good. No, very good. Okay. So in this patient, what is where your patient is taking some antibiotic, isn't it?
Yes.
What is that?
Sulfamethoxazole trimethoprim for UTI.
Okay, for UTI. So cephaloxime is already prescribed there?
No. Both antibiotics are new prescription drugs for the patient because she is newly facing the UTI symptoms.
So cephaloxime and Bactrim can go together?
Due to my review, because she has never experienced any UTI before, and this UTI is an acute cystitis induced by diabetes. So I suggest to use single administration of sulfamethoxazole trimethoprim instead of combination of this drug with cefalexin, because the no proven no proven proof that this combination drugs therapy can improve the relief of the symptoms. Besides that, the cefalexin is also not recommended as first-line therapy, as it is the beta-lactam antibiotic, which has low efficacy and high resistance. So I suggest to single-use sulfamethoxazole trimethoprim for treatment.
Okay, so sulfamethoxazole, you are recommend sulfamethoxazole and trimethoprim combination.
Yes.
Is it based on some guideline?
Yeah, based
Which
on
guideline?
I think it's according to MIMS and NCBI. The combination drugs of sulfamethoxazole and trimethoprim is suitable for the first-line therapy of UTI treatment, and the cefalexin.
Please carry on.
And cefalexin is suitable for second-line therapy if the patient is resistant to the sulfamethoxazole and sulfamethoxazole trimethoprim.
Okay, but how if which one this guideline is it latest version of this guideline?
I think due to my review, this is the latest one.
Make sure. Okay.
Okay.
Sulfamethoxazole and trimethoprim in UTI infection, actually they are. It might be little bit cefalexin might be better.
Okay.
This sulfamethoxazole and trimethoprim, it was really very good and considered first line. Current guideline also indicated somehow, but due to resistance, it is not that much in practice.
Okay.
But you counter check this thing, okay? You counter check, but I believe that cefalexin might be better option, okay?
Okay.
But you mentioned that cefalexin might cause drug-drug interaction with metformin.
Yes.
What kind of interaction is this?
If I interact with metformin by decrease the renal clearance and cause metformin toxicity, which shall cause too low blood glucose level in patient.
Okay. So cefalexin Actually, cephalexin, another issue is with dehydration. It might cause dehydration, and diabetic patients are in generally they remain under dehydration. So it is another issue. And this patient have some this patient has some diarrhea, something.
Currently, no,
No,
she is
that is
facing
fine.
UTI symptoms.
Okay, okay. Cephalexin might be good, but due to metformin drug-drug interaction and cephalexin itself, dehydrated nature of drug can worsen the situation because diabetic patient itself, due to its disease nature, they might be dehydrated. So we have to closely monitor patient dehydration status if we provide cephalexin. And this drug-drug interaction, which level of interaction is this? Further, we have to look into. So in that situation, sulfamethoxazole and trimethoprim is quite acceptable option choice for this patient. But still we have to look into. We need more further some evidences need to provide, means references, latest references, guideline or research article. Okay,
Okay.
very good. So how you will consult this patient?
First, for consultation for type 2 diabetes mellitus, I will
Okay.
first tell her, educate her about the disease nature, which this is an impaired insulin secretion causing hyperglycemic disease. And due to her poor diet control and overweight situation, I will advise her to maintain balanced diet and exercise regularly to reduce weight, and also for long-term purpose, I will make sure the medical adherence of the patients. If the patients take each drug on times, follow the instruction, and also tell her the long-term complication disease such as the neuropathy, retinopathy, and macrovascular problems.
Very good. Very good. Did you prepare this now or earlier?
I searched this before.
Okay. Stay safe and thank you very much, my dear student. It's okay. Thanks. Thanks for your
Alright.
good presentation. We
Thank you,
will
doctor.
go back to Nurul Amani. Alive?
Okay, Doctor.
Yes, please. You may continue.
So, Doctor, I just continue or need to repeat from the beginning?
No, from that slide, you may continue.
Okay. Okay, for the previous problem that I presented before, which is the changing metformin to glucoside. So I just remember the reference. I found it in PubMed, which is saying that metformin is more associated with upper GIT side effects
Okay.
compared to glucoside.
Okay.
Okay, for the next problem, which is the doctor prescribed an unnecessary drug, which is metronidazole. Metronidazole is actually an antibiotic. So antibiotic, usually we will give for a certain period. So in this case, metronidazole, the doctor might give metronidazole maybe because he suspect the gastritis is due to bacterial eradication, such as the Helicobacter pylori bacteria. So in this case, this metronidazole is a refill drug. So the patient might have taken the medication before, but the therapy for metronidazole is only 14 days. So I think no need to give metronidazole anymore if the patient have complete the therapy before. So I suggest to omit metronidazole, but I need to confirm with the doctor first why he's still prescribing the metronidazole. So if the doctor still persists to give metronidazole, so it can be given, but the number of the duration of therapy should be 14 days, and the dose should be 400 mg instead of 500 mg, and it should be given 3 times a day for 14 days. And it also must be combined with another antibiotics, which is amoxicillin, 1 g to be taken 2 times a day, and omeprazole if the doctor want to prescribe this, still want to prescribe this. But I will suggest to omit. So in this case, I will assume that the metronidazole is omitted. So for the counseling points, so firstly, I will introduce myself and confirm the identity of the patient, and then I will continue the counseling session with prime cushion techniques, because the patient will only receive new drug, since the refill drug, all the refill drug is some of the refill drug is changed to another drug, and some of it is omitted. So I will use the prime cushion technique. So I will ask what the doctor tell the patient the medication is for, and how did the doctor tell the patient to take the medication, and what the doctor tell the patient to expect. So regarding the details of the counseling, okay, for glycoside, I will explain to the patient why he need to take glycoside, which is to control his blood glucose level, and it need to be taken 1 tablet 1 times per day, and it should be taken with food, and which is or immediately after meal. Take with food or immediately after meal, but it is preferred to be taken after breakfast. This glycoside tablet may cause dizziness, drowsiness, or loss of consciousness, which indicates low blood glucose level. If the patient is affected, so I recommend the patient to not involve in activity that require alertness, such as driving. So another symptoms of low blood glucose level is headache, shaky hands, feeling hungry, or feeling weak or confused, or having problems in speaking. So if this happens, the patient need to take a drink or food containing sugar immediately. So I will recommend to the patient to bring sweets or drink that contain sugar in his bag or pocket whenever you want to go out. So an additional points that I need to point out is I will advise him to exercise regularly, but only light exercise. He need to avoid prolonged or severe exercise. And he also needs to adhere to diabetic diet, because glycoside is reported to might cause weight gain. So to minimize the risk of weight gain, he needs to adhere to a diabetic diet strictly. Next, for omeprazole. So omeprazole is need to be taken to reduce the amount of acid made by the stomach. So this is a gastric medication. So it need to be taken 1 capsule 1 time daily, and the capsule need to be swallowed as whole, to not chew or crush the capsule. So this omeprazole capsule also may cause dizziness. So same as before, he cannot participate in activity that require alertness. And the common side effect is headache, diarrhea, constipation, stomachache, stomach pains, nausea, vomiting, and pain in the stomach. So I will advise for the patient gastritis condition, we advise the patient to avoid spicy food and carbonated drinks, and the patient need to avoid lying down after eating. So this will help to reduce the symptoms of gastritis. Okay, for loperamide, so this is given to treat diarrhea. It need to be administered 1 capsule 3 times a day when needed. When needed only. When the patient is already recovered from the diarrhea, so the patient need to stop from taking it. So the loperamide capsule need to be swallowed as whole capsule. Do not chew or crush it. The common side effect of loperamide is dizziness, drowsiness, and tiredness. And I will advise the patient to drink plenty of water because during he is having diarrhea, he already lost a lot of fluid, so he needs to drink a lot of water to replenish the fluid content in his body. Okay, what if the patient forgot to take the medication? The patient need to take the missed dose as soon as possible. And but if it almost the time for the next dose, the patient need to skip the forgotten dose and take the next dose. And I will emphasize to the patient to not double the dose. And then at the end of the counseling session, I will verify with the patient whether he understand or not the points that I have taught before. And I will ask him to repeat and check whether he understand my points or not. So if he is maybe he forgot some point, I will add that point. And then I will ask whether he has any confusion or inquiries regarding this regimen. Okay. Okay, that's the end of the counseling session. So let's see the monitoring parameters. So for glycoside, so it's to treat diabetes mellitus. So we need to monitor the fasting blood glucose. The ideal fasting blood glucose for diabetic patient is below 131 milligram milliliter. And we also can monitor the glycosylated hemoglobin, and the ideal percentage is 6.5%. We also need to monitor the side effect and its severity. So because glycoside also can cause diarrhea, in which the patient already experienced diarrhea. So we need to monitor whether the glycoside induce diarrhea or not. And also ada side effect lah. And then since glycoside also may cause gastritis, which the patient already having now. So we need to monitor the symptom of gastritis, whether the glycoside further worsen the gastritis or it's just okay. Whether the symptom is just okay. For omeprazole is reported to cause hypomagnesemia. So we need to monitor the magnesium level before magnesium level of the patient before we start the therapy. And also need to continue to monitor the magnesium level after the therapy has begin in a period of time, periodically. And then we also need to monitor the sign and symptom of gastritis and its severity because before this the patient take ranitidine for gastritis and we change to omeprazole. So we need to monitor whether the omeprazole is efficient, is therapeutically efficient to control the gastritis condition of the patient. And then we also need to monitor the signs and symptoms of gastric cancer because the gastritis might be due to gastric cancer. It has probability to be due to gastric cancer. So we need to monitor the signs and symptoms of gastric cancer, such as nausea, loss of appetite, mild gastric discomfort. And then if the gastric cancer is suspected, you need to perform upper endoscopy to confirm that. Okay, that's all from me. Thank you.
Okay. Amani. Amani?
Yeah? Yes,
Apa khabar?
Alhamdulillah sihat.
Alhamdulillah. Okay, one point I think metformin, when we give with ranitidine, you mentioned that there is drug-drug interaction, isn't it?
Yeah, yes.
What kind of impact or effect it will bring?
Ranitidine will increase the side effect of metformin.
What kind of side effect?
Diarrhea.
Very good. And your patient is already suffering from diarrhea.
Yes, already 1 week.
Okay. So then why you mentioned, no, sorry, metronidazole. Yes, metronidazole might not be rational.
Because in the prescription it the metronidazole is a refill drug. It's actually need to be given for 14 days only because it is antibiotic, right?
Okay.
So just the duration of therapy is for 14 days only. So if the patient has taken this before, if the patient has completed the therapy, so I think continue this because
Good.
because
Very good. Very good. Very good. Very good. Okay. So if still patient is having diarrhea, then what you recommend after completion of metronidazole, 14 days therapy,
yes.
and still patient is affected with diarrhea, then what does it mean? What you will do? How you will manage this patient?
Metronidazole is for gastritis, right, doctor?
Okay.
So the doctor might give metronidazole because he suspect metronidazole is due to because he suspect the gastritis is due to the eradication of Helicobacter pylori bacteria. So if the
Okay.
patient has completed therapy and still having gastritis, so it means that the gastritis is due to other problems, not due to the Helicobacter pylori.
Okay, okay. So that's why proton pump inhibitor is suggested for this patient, isn't it?
Sorry, doctor?
A proton pump inhibitor, omeprazole or
Yes.
pantoprazole is alternate option for this patient is good effect.
Yes. It's to replace the
Okay.
ranitidine.
Okay, but you mentioned that gliclazide also can cause diarrhea, isn't it? Gliclazide,
Yes, as a side
you
effect.
you mentioned how much it is reported, how much percent
It's
it
actually
causes?
a common side effect. So it not really a serious side effect.
Okay, okay, very good. But you have to get more information when you share with your patient. Then you can say that it may be interaction of metformin and ranitidine, this diarrhea. Okay, but if we reduce the dose of metformin, should be fine, or replace ranitidine with proton pump inhibitor is fine. Though proton pump inhibitor is not that much good option nowadays. Meta-analysis and latest research indicated that proton pump inhibitor is not really good, though it is very powerful drug, very powerful, and it show really very good coverage, but unfortunately, there are some other complications are associated with. So that's why ranitidine, famotidine is one of good option. And currently, physician and practice, they said that if we select these two drug, it is more safer. Anyhow, if in combination ranitidine with metformin can cause diarrhea, then gliclazide is good option. But we will again monitor the patient that with gliclazide it is okay and safe, or diarrhea is continue. And then metronidazole is good option, and hopefully patient will restore his health, means diarrhea will stop. But still diarrhea is going on after 14 days of metronidazole, then we have to look into, we need to relook patient history. If what is the age of your patient? What is the age of your patient?
Sorry, doctor?
What is the age of your patient?
The age is 53.
Okay, okay, still young, not geriatric patient.
Still young.
So means we need to look all possible alternate issues that why still patient is even uncontrolled diarrhea is one symptom of HIV/AIDS patient as well. So it also can be. Anyhow, in this situation, we can go, but loperamide, the dose shouldn't be more than 60 milligram per day, which you mentioned.
Yes.
And further, the yes, where is the slide? Loperamide. 4 milligram TDS 3 times. It's okay. 3 times 4 milligram. Then it's fine. Yes. But keep in mind, loperamide shouldn't be exceeded 16 milligram per day. And then, as I mentioned just before, with the SIMV, that diabetic patient already dehydrated. This patient is with diarrhea. I discussed with Sim that it might be your Sim case. Patient is affected with diarrhea, but Noor, your case is affected with diarrhea. So diabetes mellitus disease can cause dehydration. Further, if diabetic patient cause diarrhea, gut diarrhea, then dehydration is very severe. We have to look into, and closely we need to monitor our patient. Okay, because in a diabetic patient, lot of hypertension is also involved in general. Then we have to look into those perspective. In a hypertensive patient, even antihypertensive drug can cause further issues. And anyhow, that is broad picture. Or if we focus here, then we have to look into